Good afternoon. I'm Dr. Wade, and we want to thank you for attending this final session. We have a group of esteemed panelists. We're going to answer some questions about what they do around ACEs and the opioid crisis, and then we have some directed questions from them, but also we'll have some questions from the audience as well. We'll start off just by having each panelist introduce themselves. We can start with Dr. Ortiz and go from there.
Good afternoon, everyone. My name is Dr. Anahi Ortiz, and currently I am the Franklin County Coroner. For 30 years, I was a pediatrician working in underserved communities for most of that, other than 2 years of that stint was working in underserved communities. And then in 2014, was offered the opportunity to run, put my name in the hat for this position, and then I was elected twice. Since then, I've learned quite a bit, worked on a lot of issues in the community, including the addiction crisis, and currently homicides and suicides.
Good afternoon. I'm Dale Block. I'm the Vice President, Chief Medical Officer for CareSource Insurance in the Ohio market. I focus my work primarily in the Medicaid and marketplace space. I was a family physician for a little over 30 years, practicing in multiple sites. I was just mentioning, Joe, I'm a true dinosaur in that I actually had private practice run by my wife. So you can see how much that has changed. I sit on the board of St. Vincent's Family Center, which is a day treatment program and residential program for children with behavioral health issues. When I was in the Dayton area, I was on the opioid task force, working with that group on the provider side. A little bit about CareSource. We are probably one of the 3 largest Medicaid plans in the country. We do have Medicaid, marketplace, and certainly some Medicare products. The focus, from my perspective, is stakeholder engagement, whether it's a member, provider, community-based organization, payers, other payers, focused around population health management and quality improvement, health equity, and care coordination. We do believe in a science-based, empirically supported clinical model that is integrated and informed using the socio-ecological framework and the BPS model. We also align with the Ohio Department of Medicaid and the State Health Improvement Plan, trying to continue to focus on prevention.
Wow, how do I follow that? So my name is Emily Giametta, and I'm from Columbus Public Health, and I'm the Director of Anti-Violence and Community Trauma Programs. So thank you for having me here today and talking about trauma and resiliency, and also including Columbus Public Health in this discussion. So just to give you a little bit of background, the last 20 years, I have been in the juvenile justice system and really researching and studying trauma and delinquency. So I really have been behind 4 concrete walls for quite a big, long chunk of my time. So what I wanted to share with you is just a couple of highlights that I think are really critical to the discussion today in doing some of this research, particularly with the juvenile justice system, because really that is the population that we're typically serving in these underserved communities. So one of the highlights that I thought was critical to share today is that youth in the juvenile justice system have had an average of 6 traumatic events before turning 18. And those are critical incidences and events. And that usually is a gunshot wound, witnessing a homicide, sexual abuse, emotional abuse. And so we were talking about ACEs. They pretty much max out on that list. Now, when we were collecting data and working with the National Child Traumatic Stress Network, we were noticing that our average was 9. So that was humongous. So our Columbus City kids are experiencing more traumatic events than the national average. And I just felt like that was important to say, because a lot of folks see our kids as having conduct disorders, but really they're experiencing trauma events. So, and then another highlight that I wanted to talk about today is really how important it is to have a trauma responsive program, whether you're working in the community, whether it's in a facility like I came from, and that really kind of bridged the gap to where I am today. So I'm 2 months into Columbus Public Health, and hopefully I can share some of those programs with you today on the panel.
Is this one working? Hi, my name is Stacey Swenson. I'm the Director of Behavioral Health and Social Work at PrimaryOne Health. We're an 11 health center system in Central Ohio of FQHCs. And we're actually the second largest in the state. And all but one of our health centers are located in vulnerable neighborhoods across Central Ohio. We have an 18 clinician, master's level clinicians in behavioral health that are embedded in our health center system. And all of them, our entire team, but all of them are trained in trauma focused clinical care, including EMDR. And we really see mental health and addiction as being not two separate things. And that we really work to provide that trauma-focused whole person harm reduction model of care. Our number one goal with our patients when they have addiction is to keep them engaged in care. So regardless of anything else, we just want to make sure that we can kind of keep our hands and our eyes on them. And the behavioral health department there at PrimaryOne Health is actually relatively new. Beginning in about 2015. And then in 2018, we did the trauma-informed care learning community with the National Council for Behavioral Health. And we began training all of our staff from the top to the bottom in terms of just teaching them what ACEs were. And that was just really exciting for us to be able to teach folks that were in our call center and billing, at the front desk, as well as our providers, about what is trauma-informed care and why do we care about it and what are ACEs. So we're pretty excited to be able to continue with that.
Thank you. Good afternoon, everyone. My name is LaShawn Carter. I am the Assistant Director and Chief Diversity, Equity, and Inclusion Officer for Franklin County Children's Services. My role with Franklin County Children's Services is three parts. I'm also the director of our Operations and Inclusion Division, which is our evaluation department. And our responsibility is to curate and aggregate and disaggregate all data elements related to child welfare for internal and external use. I am also over our organizational health department, which focuses on our culture and climate and our interactions internally around diversity, equity, and inclusion efforts, as well as our interaction with the local community and the residents of Franklin County in the same vein. And then lastly, I'm over our IT department. It may sound strange to figure out or think about how IT intersects with organizational health and evaluation. And for a while, I thought that too. But when you think about what an infrastructure is for an organization, you think about it as a central nervous system. And that's the way I kind of think about it. So the way our evaluation, our organizational health, and our IT systems interact with one another is really, we kind of serve as the central nervous system for the body that is serving the community. And so we make it make sense, as the video, if you were in this session prior, but we also do it with intentionality. And one of the things that we focus on is generational trauma, and how generational trauma or epigenetic trauma has an impact on the lived experiences of the young people who come in contact with our system. And our responses should be thoughtful about the traumas that their parents have experienced, that by virtue of proximity, they then experience themselves. Even if they were not the direct individual engaged in that action or engaged in that trauma, there is a expression of that trauma that lives in their genome. And so we talk a lot about that and talk about how we respond to the young people based on that knowledge, because sometimes they can't make sense of the trauma because they didn't experience it. It didn't happen to them, but it still shows up in their body. And so we need to be thoughtful about that, because even if they can't explain the behaviors, we have to realize that the body treats it the same way. And so we're thoughtful about that. We think about how our system interacts with systems like Franklin County Public Health and others. And yeah, I'm looking forward to the conversation today.
Thank you all. I think we'll start off with a question, a prepared question. I'm going to open this up to, actually we'll start with Mr. Carter first, and then anyone else who wants to answer can answer as well. When we understand the vast and complex effects that childhood trauma can have on the body and mind, physiologically and psychologically, we can more easily perceive addiction as a type of survival response, where individuals use substance to bring some temporary relief or regulation to a dysregulated nervous system. What are your thoughts about the best ways to educate others and use this knowledge to move prevention work forward?
Well, I think the first thing that I would say is to have the conversation openly and transparently about the idea that substance use disorder in many ways is an attempt to mask trauma, particularly for those who can't explain the trauma. If I can't explain it to a doctor, if I can't explain it to a counselor, if I can't explain it to a therapist, then they don't know necessarily how to treat me. And if they don't know how to treat me or respond to my trauma, then my only option is to self-medicate. And that self-medication is a way to mute the acute experience that you're having, but it doesn't necessarily address the traumas itself. And so in Franklin County Children's Services in particular, the young people who come into our system, they arrive on our doorstep by no fault or habit of their own. It's something that happened to them or did not happen for them. Therefore, they come into contact with a system like ours. And so when we think about those young people, particularly those young people who turn to substance use, it's largely as a result of something that didn't happen or intervention that was absent in their lives. And so to specifically think about how we address that is really about having the conversations around, one, what brought them to us? And then two, how do we support not just the child, but also the network of individuals that surround that child so that they can, navigate the world in a way that is responsive to the things that's happened to them and give them the tools to then, process and understand what has happened to them. And then ultimately go on a journey of navigation and self-exploration rooted in this reality that they have come in contact with some traumas that have, they have a source, but oftentimes it's elusive for the young person. And organizations like ours and Franklin County Public Health can kind of do more about locking arms to ensure that we give them access to the things that might have brought them into touch with our systems.
Anybody else?
I would love to address this a little bit as a trauma therapist. One of the things that we see a lot with our patients who have addiction and trauma is that they feel intense amounts of shame, which is an incredibly painful emotion to experience, especially when they don't understand it intellectually. And especially if they've been, it's something that they've seen, not just epigenetically, experiencing in their body and in their psyche, but also generationally in their homes where they've seen addiction. And so it doesn't, it's just the natural course, I feel like, of a disease that comes from trauma originally. And then when they try, oftentimes when they get into treatment and they try to get off of these substances, all this shame and trauma comes up and it's very crazy making for them. We hear that a lot, I feel like I'm losing my mind, or the experience of, going through withdrawal where they're just going to be in incredible amounts of physical and psychological pain. And the antidote is right there on the street, and so that they can stop that pain. And so it just makes so much sense to us that the two ride along together.
Just really quickly, in the beginning of my term when I started working with addiction, I started doing a lot of speaking on addiction. And a lot of that was to give folks the background on how it comes about, the medical reasons, of what addiction is, therefore trying to reduce stigma. What I found was people kept asking, well, why, why does it happen to this person and not this person? What is it? And then I realized, well, people aren't informed, they don't understand, risk factors and resilience. In other words, ACEs, right? So I started including slides on ACEs, and the amount of people that did not know what ACEs were was astounding to me, because I've known about it for so long, right, as a pediatrician. And so I guess my key thought here is, integrate it into your work. And if any of you do any kind of speaking, any kind of educating others, make sure that that's integrated into your talks, so that people understand, why it happens to some people and why not others.
I'm going to take a little take on this. Let's talk about the providers and the clinicians. Toxic stress is at its highest level. We talk about physician wellness all the time now. And I think that instead of an integrated system of care, we need an informed system of care. Person-centered care from an individualized perspective, but also go back to that medical home model. I can't tell you the number of our members that struggle to find consistency in a primary care physician. It's challenging. If you have a lot of issues and you bare your soul, and the next day you get a letter that provider is leaving the practice, and that happened to my wife, by the way. So doctors aren't immune from it either. It is really disheartening. So I talk about the 3 C's: collaboration, coordination, and cooperation. And that alignment of the clinical area to the managed care organizations, especially in Medicaid to the state level, they all need to be aligned and focused if we're going to see improvement in prevention, especially as it relates to substance use disorder.
Sure. Just kind of piggyback a little bit on that. I think bringing people together and the importance of the system responding is really critical, especially with the background being in juvenile justice. We really were in silos. And then we do a reentry meeting and we would be the only ones there. And then a lot of kids were misdiagnosed. And so I would say probably 90% at least were having trauma reactions, and they were coming in with a plethora of other diagnoses. And so I think it's critical that everyone's at the table. Education, if children's services is involved, if a therapist is involved, if the school's involved, and most importantly, engaging the families and, moving from that point forward. So a lot of times we're just treating the child, and we really need to treat the whole system.
Do we have any community questions?
Currently, no questions.
All right.
How do you talk about kind of getting that message out to the community? And there's this great debate between it's a moral failing and a choice, and then the physical hook to an addiction. And what complicates it even more when you start looking at other addictions like gambling, where there isn't a physical hook. What's the best way to communicate? That's the hardest thing, I think, for people that are so set in that mindset that it's a moral failing or a choice, and making that correlation. Does that make sense to you? Communicate that.
One of the things that I see is that it needs to start with us. I know that our field that provides treatment oftentimes still has the backdrop of that belief, even though we know that most addictions are a disease that start in the brain, and yet when we're treating it, we still have all these criteria around excluding people who don't meet certain criteria, or they flunk out of 6 different programs, or they've been through rehab or detox 5 or 6 times and nobody's ever talked to them about trauma. So I think that's one of the places that we really need to start, is informing us so that we can do a better job of trying to explain the complexity both to the folks that we work with and our communities. Because if we don't understand it and we don't have a way of seeing it through that lens of being trauma informed, it's going to be very hard for us to expect communities to do that.
I just bring it back to the science and making sure everyone understands that addiction is a disease. Just like, you know, and I equate it to hypertension and diabetes, etc. And then I always go into the science of it, you know, what happens, etc. Some people will listen and, you know, and understand from that. And I have heard, you know, after hearing that it is a science and hearing all the explanations, that some people do begin to understand it better. And some people, no matter what you say, will always find it as a moral failing. But at least trying that aspect first, you know, trying to give that background and science of it sometimes helps, and equating it to hypertension and diabetes.
And I'll add, just from a children's services standpoint, is that especially when you think about morals and ACEs, you can't truly think about either without accounting for the environment. And the environment has a role in how we define our morals and also how we define something like ACEs or addiction. And unless we're willing to have an honest conversation around how those morals are shaped by the environment or what has happened to that community where the trauma is playing out, then I don't think you can make a true moral argument or a moral judgment, because you haven't truly assessed the environment and gave a fair diagnosis of what has happened to that community. And so you're legislating morality, but you're not legislating the immorality that happened to the community. And I think that's incongruent.
And I would add that historically, so not just what happened currently.
Right, exactly.
I believe, be correct if I'm wrong, that you have to take historically from what has happened generations with trauma from community, family, persons, etc.
Absolutely. Yes, I agree with that.
Just have one more. Oh, not to do that. As a note, when you're asking questions or responding, you have on the table, so please turn on the microphone. You hit the speak button.
Oh, just to add what you said was morals, but the other thing, when young children are growing up, values is another word that we need to think about too, because children, young people learn values along with those morals. So that's another thing we need to keep in mind, just the word values.
Yeah, you can't define those terms absence of context. And I think that's essentially, you know, where we're headed in terms of the context of the environment. It's impossible to define those terms without recognition of that context.
Turning off my mic so that I don't interrupt. Let's have another question. We'd like to direct this to Ms. Giametta. How do you see the relationships between ACEs, social determinants of health, health equity, and addiction play out in your work? What do you find to be the most effective strategies for intervention in both the short and long term? And then after Ms. Giametta, anybody else can answer.
So what comes to mind is a recent study that I read. I think maybe it was Columbus Public Health that was a part of that study. And they were looking at Franklinton. And that's really an underserved community here in Columbus. And what they found was that the average of age expectancy was 60. So that was shocking to a lot of folks. You know, what Columbus Public Health typically does is after there is a traumatic event or a homicide, we go canvass the area. So we certainly weren't surprised by that study. And just to let you know that if you're living in Worthington or Westerville or the suburbs, it's 15 years later. So I think that that's a really good comparison to show that it's absolutely affecting health, just simply where you live. And just to share what I do see on canvases, typically when we are responding to a homicide in the community, we're looking at really poor housing. The last one that we visited, there was flooding in some of the homes. Just to kind of give you a real perspective of where these people are living. And I think the value of that boots on the ground perspective, it does have a lot of value, because then we can collaborate with Department of Neighborhoods and say, this house is vacant, this street needs, some kind of, road bumps. We have noticed that, there's a lot of litter on the side of the road, and then really work towards that angle and really work on those environmental pieces.
I think one important thing to do is to have a critical eye. That research is constantly coming to us to evaluate trauma-informed and empowerment approaches, looking for that empirical support for what works in community healing. So leading with the science is critical in any type of conversation where there's the possibility of having one's values creep into the conversation. We learned a lot about that through COVID-19 vaccination. Lead with the science. The other thing too, to really foster community healing in the short term, the trusted community advisor. That individual cannot be overlooked. And in fact, one of the things that the Medicaid plans in the state recognized when we were starting to work with COVID-19 vaccination is that we couldn't understand well enough from where we were sitting why anybody wouldn't want to get vaccinated, until we then started talking with trusted community advisors who helped direct our resources and our dollars to the right place in the community to get those that were hesitant, to get those that were on the edge. And we saw the numbers go up. I think in the long term, we really need to focus on closed loop referrals to community-based organizations focusing on social determinant of health mitigation, and smartphone technology to transform care coordination. Now, I say that with tongue in cheek because one of the things that we also have learned as a Medicaid plan is what we call the digital divide. Most of our vulnerable populations don't necessarily have a smartphone. They don't maybe have minutes available. They don't have data minutes available to do, the latest and greatest. So we're focusing on putting Wi-Fi in different communities. We are working with partners to have iPads so that when the kids were virtual, they actually didn't have to share one phone and sit around there. So again, I think it's really important to engage in the community and understand it from that perspective, not from our perspective.
Just a couple more. Nowhere but in the coroner's office will you see social determinants of health, ACEs, health inequity collide in one person, in several people that come in. Last week we had, I walked in the morning to be horrified to find a 40-something-year-old gentleman who died of his diabetes because he could not afford his insulin. In the same week, we had a 37-year-old African-American young lady who died of asthma, who was not getting regular care. So I can honestly say every day in our office, we see these collide. But nowhere in terms of addiction, we are seeing more and more. We have an addiction specialist who happens to be sitting right here, Brianna McLone, who has been able to bring forward so much information on addiction and how all these different elements play into each person who dies of addiction. And in terms of short and long term, I'm going to say short term, we both agree harm reduction is key right now in addiction, and also reducing stigma. Stigma is still there. Long term, we're just finding, treatment has been an issue because treatment is a one-size-fits-all approach, needs to be individualized to the person, to the race, to the ethnicity, to the gender, etc. And the other is identifying those children at risk of, those families who've had a death, etc., or who we know are in addiction, and working on prevention so that they don't fall into the cracks, so that they don't end up in our office.
And I'll just add for children's services that in one way or another, these are the factors that, if you dig deep enough, these are the factors that lead to incidences of abuse and neglect. Even in our most egregious of cases, if you dig deep enough, these factors kind of sit at the root of those incidences. And so one of the ways to address that is broader community dialogue and conversations around these issues, helping to support with intentional action and interventions around how to respond when you are in crisis, particularly when dealing with parents who might find themselves in crisis and may take that out on their child, which will bring them into contact with a system like ours, informing on, some of those more approachable ways to deal with those traumas that won't lead to their children coming into our system, because that creates a cycle and a perpetual loop of contact for that child and their family. And that's ultimately what leads to those two generational experiences where a young person who was abused or neglected becomes the parent that is now abusing and or neglecting their child. And that's usually rooted in the fact that there was no intentional intervention ever introduced to that child or to that parent that would stop or break the cycle. And so being clear about these particular factors as a way to explain the experience, and then inputting appropriate intervention around those factors so that they can see themselves in the solutions, and feel empowered or engaged in a way that humanizes the experience. That's really truly how we can kind of break the cycle of trauma, or how these social determinants or ACEs influence children and families becoming in contact with child welfare or child protective services.
It's one of the reasons I think that, in primary care and pediatrics is such a perfect place to have these conversations, because by the time children's services is involved, that's another traumatic experience, right? And so I think having those conversations and creating system change through insurance companies and payers who will allow for that 40-minute visit to have those conversations, because if it doesn't happen before there's more trauma, then it just becomes another layer, and then they're just jumping through hoops so that they can get their children back, or so they can avoid consequences. And then they're lying because they know if their urine drug screen is positive, they're going to get in more trouble, or they're going to go back to prison, or and so I think we really as a system have got to start thinking of better ways to help doctors, honestly, because it all falls on you guys anyway, right? Like, your primary care all the time. Like, we have a really robust behavioral health department that works shoulder to shoulder with our medical providers, but we still only see 12 to 15% of our population, even though we know probably 95% of our population could use counseling, but for whatever reason, they're just not ready for it, or it's not convenient. Or, there's a long list of reasons. But we know that primary care is where they're seen. They're seen in women's health, they're seen in pediatrics. And so I think as a system, that's the smartest way for us to move forward, is by helping physicians and primary care be able to address these needs.
Do we have any audience questions?
Denise asks, at ETSS, we provide services for new Americans, immigrants, and refugees. Finding culturally and linguistically appropriate services for mental health and substance use disorders has been difficult. In some cultures, there is no word for depression or other mental health diagnoses. Also, trauma and stigma are common. Any suggestions? And as a note, people on the chat have been saying it's been difficult to hear for the microphones, so try to keep them as close to your mouth as possible. Thank you.
I hate to jump in here and be the big mouth again, but you know, I know that again, you know, where there isn't language to discuss some of these issues, there is still language to discuss certain elements of health. And so again, that relationship can be built. We have two Somali-speaking clinicians on our team, but they rarely see patients who are Somali, even if they go in and do screenings and try to do relationship building. But again, all of that takes time, right? And time that things aren't billed, then you know, I mean, it's that whole treadmill of getting services to people and getting them paid for. But again, I go back to primary care. Sorry.
I'll add that for us, you know, one of the ways in which we solve for that particular issue is through relationships and explaining the experience in the way that makes sense to you. And then we diagnose how we respond based on your explanation rather than us using the Western textbook of defining things as a way to, you know, understand someone else's experience. And so we had a similar scenario where, you know, we were getting a lot of pushback when we were trying to do some outreach into certain communities where, you know, we're, you know, doing the tour. Children's Services is coming out in your community, and we wanted to do some outreach to fathers in some communities. And what we were finding was, you know, it wasn't that there was not a desire to interact with us Children's Services. It's that we were using the wrong language. The way that we had been describing ourselves, it might sound funny, maybe not, but the word we were using for services translates to support. So people were confusing us for child support, not children's services. And so it's very important to have people who understand the nuances of language engaged in the process of outreach. Otherwise, you could be defining yourselves in ways that could be counterproductive to what you're trying to do. And, you know, ultimately, we figured it out, but I would say it's truly rooted in relationships and having people who are experts of the lived experiences defining for themselves what's going on in their community and what's going on in their homes.
So I have another question that I'll direct to Dr. Ortiz. Racism was recognized as a public health crisis in Columbus and Franklin County in 2020. Community traumas like the COVID-19 pandemic add to the urgency of this statement as we continue to witness more deleterious outcomes, physically, economically, and socially. Among those groups who have been historically discriminated against, how do we use the information discussed today in our day-to-day lives to work toward purposeful change? And then after Dr. Ortiz, anyone else can answer.
I'm going to try and get this close. I think it's the mask that might be occluding speech. But so I think the key word is being mindful. Knowing, you know, what racism is. Knowing it exists. Being mindful in your approach every day. And right now, I'll just speak on my own experience in my office right now. But when I walked into the office in 2014, there were very, very few people who look like me, who look like you, people of color, period. And I asked for a list of employees, and I ended up meeting everyone. So I knew really percentage-wise how many were, you know, African-American, Hispanic, no Asian, et cetera, et cetera. And I made it my point to try and make my agency more, one, culturally sensitive, two, to look like the people that they serve. And so I have tried different recruiting methods, but we have increased our diversity in the office tremendously from when, I walked in 2014. I made sure that I brought in speakers to educate my staff on different religions here in Franklin County, on different groups that are here, the different cultures that are here in Franklin County. We've held just, different culturally relevant celebrations, etc. And we make it, I've brought in other speakers to speak on how to be sensitive, to the point that now when I first walked in, for example, no one really knew what to do with our Hindu and Muslim families that were, working with those who died that were Hindu and Muslim, because they didn't know about the religion. At this point, we know exactly, that they have to be, we have to work on them quickly because their last rites depend on time. And we work with the mosque, we work with the Hindu leaders, etc., to try and get their loved ones back to them within a certain period of time. We also now work on, there are certain religions that do not want autopsies, namely the Muslim religion. When it comes to a homicide, that's just not always possible. But we have worked throughout the years with the mosque. And now we actually have a prosecutor, believe it or not, who's Muslim, and she helps us speak to the mosque in terms of bridging that divide. So again, it needs to be a mindful approach. You need to see where you're working or your family or, whatever, what the situation is there, and then be mindful in terms of your approach and how you're going to do things.
I'll add to that by something that I think helps certainly guide me, and that is being intentional, using cultural humility and empathy as I engage with individuals and communities for what they prefer and need, in this case, to self-heal. Oftentimes, I think we bring our own agenda to the conversation, and that's our focus, and it really isn't. Everyone's entitled to their own opinion, but they're not entitled to their own facts. And it's an old saying that rings true as we work through a lot of the community issues that are certainly in our consciousness today. I also think that, we can bring the community in and work with them from a research perspective, certainly from community-based participatory research, where we promote trust and transparency and accountability. But the research is driven by the community. Yeah, it's empirically supported interventions, but it honors community knowledge. It promotes community self-healing, and it addresses and closes health disparities. And that's one of the, I think, great research tools to use in this context moving forward.
So I'm going back to my JJ experiences. Oftentimes we provide service, we need to provide services in a framework that recognizes racial trauma. And, example of that, especially in the kids that we serve in these underserved communities, they really feel like that the just world perspective doesn't apply to them. So, typically in the neighborhoods that we live, if there's a shooting, if there is, somebody gets sick, if there's an emergency, police respond, fire respond, the environment is typically safe. So generally the families that I work with, they feel like the social contract is broken. And I think that's so important to acknowledge that, and really to focus on the empathy and compassion, because that's really what's paramount right now, and starting there. So that's kind of a little bit of my perspective.
So I'm gonna offer 4 specific things to answer this particular question and structure it as a cycle. And the first thing that I would recommend anyone that's trying to figure out how to implement this type of work that's addressing racism into their day-to-day lives or even their profession, the first thing they would do is engage in consistent action. What that means is choose the path that will unlock the potential for conversations, but make an intentional choice that you can consistently show up on every time you're having these conversations. So for example, with children's services, consistent action for us is we disaggregate every data point. What that means for us is whenever someone asks us for data, whatever the question is, that the research question, however the research question comes to us, our answer is always going to be in a disaggregated format, because we want you to understand 2 things. We want to give you what you've asked for, but we also want you to understand how specific communities are experiencing that question. And that's a way to amplify or uncover the disproportionalities that can be hidden within data. And what we also know about racism is that it can be subtle, it can be nuanced, and it can hide in data if you're not intentional. So the first thing we do from that standpoint was we engage in consistent action, and we do that by disaggregating every data point. The second thing we do is we do not avoid the necessary conversations that function as elephants in the room. So organizations who are trying to respond in this current cultural climate don't do themselves any favors when they avoid these type of conversations. No matter how uncomfortable, how difficult, or even for those who, when the race topic comes up, they begin to roll their eyes because you're talking about race again. Avoiding the conversation undermines the process, the progress, and the solutions. So again, have the conversations consistently, but make sure they're front and center and seen as necessary to whatever services that you're providing to the community. Don't avoid the necessary conversations. Number 3, acknowledge the historical context, because the historical context is critical to understanding what's happening today. I'm gonna go to this gentleman's point a little bit earlier, right? If we wanna understand why there might be vaccine avoidance in certain communities, the answer can be found in historical context. Now, whether or not they are interpreting that historical context correctly doesn't change the fact that it's influencing their choices. And so understanding that and being able to respond to that helps to inform how you then go out to the community and interact with them. So it's understanding the historical context is step 3. And the last one is expect and accept non-closure. You're not going to change the world every outing. You're not going to change a mind every outing. But the point is, you expect it. You expect that reality. You also accept that reality. But once that reality lands on you, you repeat the cycle. You go back to step 1, right? So that's my answer.
Do we have any more?
Can I just ask a very quick question? So one thing that we haven't talked about, and it's not often talked about, is the impact of trauma, and for this discussion, the ACEs that
The
comes
people on the virtual can't hear when you just.
that comes through culture, specifically America as it is today, through the form of media. music, TV, etc. And I'm not specifically talking about music, media from a African-American cultural standpoint. There's a lot of violence, pervasive, period. And unfortunately, for those that I'm looking around that are probably 40 years old or such, we know in the last 10 or 20 years, there has been a tremendous destructive impact. And so I think when we talk about trauma, that clearly does not get addressed, because you see this continued violence and substance abuse, if you will. Look at the legalization of marijuana. You know, people talk about, you know, the holistic point of view, and I'm for holistic, but driven through the media and that picture that it gives, let's say, to our youth and young people, it does not come through holistically. It comes through very destructive. This whole violence piece, when you talk about murder, guns, etc., you know, that's driven from the top down and literally handed from a trauma impact standpoint to people who are struggling with this. And it just totally gets unaddressed. So we're talking about communities and families and et cetera. But if you look at the last 20 years of what has come down through media, just driven through media, right through cell phones and all sort of electronic devices that our children and communities and family have to deal with, that has a direct impact on what we see in trauma today. And I often do not hear that touched on at all. Thank you.
So, giving you a workout, Teresa.
Look at it. I need my step.
Yeah. So, I agree with you. And so, in my former life, I was a youth-led programmer. And one of the exercises we did when we were trying to understand ACEs is kind of something that you're touching on. And we had a program where we call Identify Their ACEs, where every student in the group, I was a teacher once upon a time, where every student in the group got to pick their favorite musician's song, or one of their favorite musician's songs. And so we said, listen to the song and count their ACE score. Like, what are they telling you? Or how are they communicating their trauma to you through their music? And the powerful nature of that experience transformed some youth to understand, like, one, music is a modality for communicating, but then two, it's communicating trauma. And kind of taking your point one step further is our access to others' trauma is heightened. You know, social media, this is not railing against social media as a user of it and a consumer of it, but it is an acknowledgement that we have greater access to each other's trauma by virtue of social media, and that passively impacts our own self-esteem, self-awareness, and all the other social determinants of health, right? We have a passive awareness of each other's trauma that we didn't have once upon a time. Now, here's where that can be powerful. If we responded with that understanding, with empathy and compassion, and actually did something with that information that was positive, it could be useful. But when you experience that in a silo with no one to help you to navigate or process what you're experiencing, then that trauma becomes yours and it plays out in these detrimental and negative ways. So, you know, I think you're right, but it's something that with thoughtful collaboration, we could use as a tool rather than a device for destruction.
Okay, so we're going to wrap up now and offer some time for Joe and Teresa to come in and talk a little bit and summarize our discussion. We want to take this time now to thank our panelists for their thoughts and comments. Thanks.
All right, one more reminder.
Good afternoon, everyone. Thank you so much for attending today's summit. Before we get to our closing remarks, I just wanted to give everyone a reminder to please complete the CE application form if you're interested in receiving CE credits for this summit, and also to make sure to complete the evaluation, which will be emailed to you post-summit. Please complete that within 1 week. So that means please complete it by October 26th at 11:59 p.m. Thank you so much. And I will hand it over to our leadership to close us out.
All right, and hopefully I won't duplicate anything that Joe was planning to do, but first of all, I want to thank all of our partner agencies that were part of our planning committee. We appreciate all your input, your time, because we know right now everybody's extra busy. So we value your time and we appreciate that. And then I want to have all of my team, please stand if you're not already standing. Most of them are standing in the back. Please, this group, yes. You guys don't know the time commitment and dedication this group put into planning this summit. People were having nightmares, but it all came together. It was wonderful. And I just want to publicly thank them all for their work, their dedication, while also keeping up with all their other work. So thank you all. Those are all of my comments. Thank you all for participating. Thank you all for everyone on virtually for your participation today. And I'm going to hand it off to Joe to close us out.
Great. Thank you, Teresa. And I did have that on my list. So thank you for mentioning that. I do want to thank our staff, just extraordinary, and our partners, our planning partners. Let me pick up on the thank yous and say thank you to our sponsors as well. I hope that everyone had a chance to visit with them at their booths. And this summit literally would not have been possible without their sponsorship and their funding. And so I thank all of them for your partnership and for your dedication to this event. When Teresa mentioned this a few months back to say, I think we want to host a summit with respect to adverse childhood experiences and ACEs. And I said, well, how are we going to do that? With everything else that's happening in this community, how are we going to do that? And Teresa challenged me and said, we have to do this. We have to have this conversation. And I said, I'm 100% in agreement. And now, having had the conversation, I'm so thankful that we did. This has been an extraordinary day. Quite honestly, one of the best days I've had in a long time. It's a sobering day, but it is a hopeful day. And I genuinely want to thank everyone in this room, everyone wherever you are on Zoom who have joined us. This has been a partnership. This is about our community. This project was selected by our Prevention and Education Subcommittee for the Columbus and Franklin County Addiction Plan as its legacy project. And I want everyone to know that was an intentional decision made by that committee, that when we think about our work, from a legacy perspective, what can we do to really make change in our community? And this was the project that they selected. They said, we want to support this summit and make it an extraordinary day and make it a meaningful day and make it a day that's about change and about how we can as a community move forward. And I hope that this conversation achieved that. I think it has, but it's not just about today. It's about what we do when we walk out the doors, as we always talk about. It's not just about this conference. It's about what's going to change now as a result of this conversation. And so I'm going to ask our staff to help work with all of you to put together that action plan, if you will, to put together those next steps, to put together those observations, to put together the takeaways, and then follow up with whoever we need to follow up with, whether it's Future Ready Columbus or the Rise Together plan or our addiction plan or Celebrate One, our infant mortality plan. Well, whatever partner we need to follow up with, it's about taking this discussion and moving it forward and aligning it with the work that's happening in Franklin County. And, there is tremendous work happening in our community. You heard that from our elected officials. You'll hear that from both health departments. You hear it from everyone here sitting around this room and who's joined us online. There is hope here. There is hope, but we need to recommit to that. This has been a very traumatic 18 months, 20 months now, but this is not a new issue. This is not something that's new, but something that certainly has been exacerbated by the pandemic. And we need to think forward and think about, where is this community going? And it's this conversation that I think is really going to help inform that. And so I'm very, very grateful for it. I want to thank everyone who spent the day with us today. You'll hear from us as kind of a next step. But on behalf of the Franklin County Board of Health, our staff, and all of our partners, I truly want to thank each and every one of you for your contributions today, for everything that you do for the residents of Franklin County. So hope everyone has a great rest of the day. And Teresa? Yes, we have some colleagues who've traveled internationally from Mexico City to be with us, to learn about what's happening here in Franklin County. I think we're going to do some interviews and have some more conversation there. So certainly a unique opportunity, and thank you for making the trip. We heard about how your travels went from Mexico City to New York to Cleveland and here, but you made it, and we're so glad that you did. So if you think you had a long commute today, there you go. So on that note, thank you so much. It's great to see some of you. It's to see people again. And thank you for giving me more hope today. And I hope that this conversation gave you more hope as well. And we'll talk to everyone soon. Have a good rest of the day. Thank you.